Welcome back. So we shall proceed, and the next couple presentations will be on myeloproliferative neoplasms. So it gives me pleasure to introduce as the next speaker. I hope that Ruben is on. Are you on, Ruben?
Yes, he's on. There he is.
All right. Dr. Mesa is, of course, no stranger to this forum. I think he has participated in all but one of our patient conferences over the past 15 years or so. He is a trainee of, here he is, of the Mayo Clinic, first in Rochester and then in Scottsdale, who has moved on and is currently the executive director of the Mays Cancer Center in San Antonio. He is well known for his work in myeloproliferative neoplasms, where he is clearly one of the international experts. He initiated and contributed substantially to the guidelines that have been developed on symptom management, but is also involved in many trials trying to advance the therapy for patients with MPN. There are many other functions that he has that I could list, but I think in the interest of time and focusing on MPN today, Ruben, welcome, and please go ahead.
Well, thank you so much, Joachim. It's a tremendous pleasure to be with the meeting today. Certainly, I lament that we're all able not to meet in person at your lovely campus on the beautiful Lake Union. Although if I heard correctly, you guys are having a completely un-Seattle-like weather with temperatures over 100 degrees. Which must be quite memorable.
Somewhat unusual.
Somewhat unusual. A lot of people jumping into Lake Union itself, I suspect, to cool off. But great to be here. This is a wonderful meeting, and I think it's particularly helpful for patients with MPNs and MDS to both learn about their disease, but also to hear a little bit about the other diseases as well. There's a lot of overlap. There's a lot of shared knowledge that has been gained. There are therapies developed for one that sometimes are applicable to the other. So there's a lot of reason for discussing them together. So my task is to walk you through a bit how we view the non-transplant therapy for MPNs in 2021. And Joachim, are you able to see my slides okay?
Yes, I do see your slides.
Wonderful. Here are my disclosures. And as Joachim had said, I've been involved with most of the drugs that have been tested or developed. So we're going to focus a bit around how we treat the disease, some of the evolving data and the medicines that we use. And all of this gets boiled down to help to provide guidance for treating physicians both in the US and elsewhere, in terms of what we call treatment guidelines. Guidelines aren't perfect. They are made by committee. This somewhat of a Mad Men sort of photo here, but a committee of folks looking at the data, trying to come up with the best guidance for patients in a particular disease and in a particular situation. Now, another way of thinking about treatment guidelines that I think is more accurate is treatment guidelines are providing a bit of the guardrails, meaning for a certain situation, let's say a newly diagnosed young patient with essential thrombocythemia, what are the options that we feel are reasonable to consider? Now, there's many individualizing factors, age, symptoms, other medications, allergies, etc., that certainly might modify what you end up selecting. I view that even in medicine, when we have guidelines, there still is a tremendous amount of very important decision-making that occurs. This is really the art of medicine. How do we apply what is selected? Indeed, as we think about the balance between my talk and Joachim's talk, part of the art of medicine is us trying to work with you to determine which patient is an appropriate individual to move forward toward transplant and which patient it's best to proceed with medical therapy. Now, before we talk about treatments, we really have to talk about how did the disease affect you? And then how do treatments impact that burden? Our goal is to have the disease be as invisible in your life as possible. Now, the burden of MPNs is quite variable. If we were all in the auditorium at the Fred Hutchinson Cancer Center, could look around and see that there's young patients, there are older patients, there's men, there's women, there's people of every ethnicity, race, gender, and however we can think of the things that distinguish us. So it's a very heterogeneous group. And similarly, how they're affected is very heterogeneous. There's risk of vascular events, meaning blood clots or sometimes bleeding. There are risk of the blood counts being low. That's more common in myelofibrosis, but can be present in PV or in ET. There can be enlargement of the spleen. This does tend to be one of the main differences between the MPNs and MDS. Enlargement of the spleen, increased number of cells, all of that more aligned with MPNs. There can be symptoms, and we'll get into those to a greater degree. We think that they have a variety of drivers, inflammation, and other difficulties. And they are diseases that can progress. Indeed, for many individuals that are afflicted, it is progression that potentially makes the diseases problematic or life-threatening. But all of this occurs in the context of a person. No one is a disease. You are an individual with your own history, your own genetics, your own culture, your own, let's say, medical history. And all of these, your own level of fitness, all of these things weave together to impact when you are afflicted by a disease. So you can have one individual with the same disease and put it in a 30-year-old or a 70-year-old, and they're going to behave quite differently. Now, our group has been really interested in trying to quantify some of the subjective aspects of the disease. And there have been parallel groups that have done a similar effort in MDS. You know, if you're telling me you're tired, you have night sweats, you've lost some weight, you have itching, you have some bone pain, you know, how do we ask that? How do we track that? How do we quantify if that got better or worse in response to a therapy? So we've created a series of questionnaires. They've been tested in a bunch of languages, been used now in over 50 different countries. And we have identified that the experience is remarkably similar across the globe. There's some slight cultural impact in terms of how severe people rate symptoms, but the experience is pretty consistent, whether we're talking with patients from Uruguay, Japan, from Washington State, or from Europe. Now, what sort of symptoms? Again, some of you might not have any symptoms. That can occur in up to 50% of patients with ET and maybe up to 30% of patients with MF. But many do, and they're variable. By far the most common is fatigue. Insomnia is very common, and that has a variety of drivers. There can be issues of sad mood, and sometimes, of course, the uncertainty of having a difficult disease can lead to depression. There can be difficulties with concentration from anemia, medications, or others. There can be early satiety, filling up early, inactivity. Issues of intimacy are very common. They're not frequently discussed, but they're real. And many of the ways that the disease affects someone really can impact either sexual functionality, but also desire. Night sweats can be common and are linked to inflammation, dizziness, abdominal discomfort, bone pain, headaches. cough, weight loss, fevers. Now, not all of these symptoms are equivalent. Some of these symptoms I find have been associated with evidence of progressive disease, in particular losing weight and fevers. Now, using questionnaires, both in practice and in clinical trials, has become very common and certainly has become the standard across the large clinical trials which have gone on in the past and which are moving forward in the future. Now, we do know that how you're affected by the disease and how you're feeling does evolve over the course of the disease. MPNs are very chronic diseases. Patients with PV or ET frequently have the disease from 10 years or more. Myelofibrosis patients have a more severe disease, but sometimes have the disease for 10 years or even decades. And over the course of that disease, there can be the impact of the disease, medications, and other events that make the symptoms and impact of the disease kind of increase or decrease in the individual's life. So one of the key takeaways in terms of medicines is that any medicine that you're on for an MPN really needs to be tracked over time, need to be visiting with your physician, tracked with blood counts, and seeing whether it is achieving our goal. Our goal, again, is for you to feel as normal as possible, to be protected against blood clots and bleeding, and in the ideal world, trying to protect you against progression. Now, there are many things driving the biology of MPNs, both genetic changes, which you've heard of some of that earlier today with similar genes that sometimes are impacted in MDS and MPNs, but also there is a range of different things which occur in the body, including inflammation that can lead to symptoms, enlargement of the spleen, and might increase that risk of blood clots. Now, I had mentioned earlier that MPNs sometimes can give us challenges with depression, mood, anxiety. And in the past, people used to think, well, are these symptoms really from the MPN, or are they really secondary to depression, anxiety, etc.? The reality is it could be a bit of both. There is no question that if there is a tremendous unresolved issues with anxiety or depression, they clearly impact how people feel. It can impact the immune system and clearly can be a factor. All of that said, I am here to validate that symptoms that you have from the disease frequently are very real. They can be linked to the biology of the disease. Many of them sometimes do improve with therapy and can be a helpful way of tracking the disease. Now, indeed, one of the things that myself, my colleague Ruben Mesa, and others have tried to do is try to better understand the biology of these symptoms. Why do they occur? Fatigue sounds simple, but it is a very complex and frequent difficulty people face, and there's a variety of linkages, both with inflammation, changes in blood counts, impact of medications, and others. Abdominal symptoms have many different origins, not only the size of the spleen, but many issues, including flow of the blood, inflammation, and other difficulties. Constitutional symptoms such as fevers, chills, night sweats, weight loss, all have a variety of different drivers, many of which sometimes do improve with medical treatments. Microvascular symptoms. These are symptoms related to the flow of the blood that can have a variety of drivers, and again, are important for us to try to impact favorably. Now, we try to weave all of these things as we try to come up with our treatment goals. What are our goals? Is it avoiding thrombosis and bleeding? Is it improving symptoms? Is it to try to increase activity or decrease the enlargement of the spleen? Are we trying to improve low blood counts? Are we trying to live better? Are we trying to live longer? Sometimes we'd say, boy, we'd love to do all of these things. But very clearly, many of our medicines are things which do one or more of these, but very few do them all. So our selection of medicine, dose, and adjustment sometimes really depends on our dose. So let's start a bit with ET and PV. Now, first realize that these diseases are dynamic. People have them for a long period of time. They can progress to myelofibrosis sometimes after 10 years. Now, early on in the course of the disease, the first several years or sometimes many years, the issue is really high blood counts, high platelets, high red cells, high white blood cells sometimes. There can be symptoms. The symptoms can evolve over time if the disease is progressing. For example, issues like weight loss might show up really after someone's had the disease for many years, whereas issues with headaches and difficulty concentrating from high counts is much more common in the early course of the disease. Progression does seem to have a link to time with the disease. Risk of vascular events does seem to decrease over time, but it does not go away. Now, as we manage ET in 2021, we diagnose the disease, we assess survival and disease burden, and for many, their survival might be very close to what we might expect for other individuals of your age. We develop a treatment plan. We start with our frontline medical treatments, which in 2021 typically is, by the current guidelines, either hydroxyurea or pegylated interferon alpha for a subset of individuals, those individuals that have higher risk disease. Others may be on aspirin or even observation. Now, if they progress to MF, we treat them like myelofibrosis, or we have second-line therapies in development. Now, there are many questions that remain in 2021. I mentioned hydrea or interferon. Which of these is better? In MPN communities, if you ask that question, you might get people into a fist fight in that there's equal numbers that are argued one way or the other. There is data for both in ET. How do we prevent disease progression? Should we be thinking about JAK inhibition in ET? It's approved in myelofibrosis and in PV, and it's been tested in ET. Now, there are therapies that are in development. There are new therapies in PV that we'll go into a moment. In ET, there's a ropegylated interferon. Currently, there's a national trial ongoing led by Dr. Verstavchuk at MD Anderson NI. And there is a second-line therapy also at my center, but also many others with the LSD1 inhibitor from Imago, IMG 7289. Now, what about polycythemia vera? Well, polycythemia vera, we've got several things in development. I'll share with you first that we're starting to learn more as we study the symptom information from clinical trials. So we did a clinical trial comparing hydrea or pegylated interferon in individuals with ET and PV. And in short, we found that through 1 year, the drugs were equivalent in terms of ability to control counts and relatively equivalent in terms of safety. It is felt with other studies, the ropegylated interferon studies, that over many years, perhaps pegylated interferon may have an advantage in certain subsets of individuals, but that may come at the expense of some higher side effects. Now, in these studies, we decided to look at the symptoms and quality of life. These were patients in both of these studies. 111 was a study in the second line for people that had failed hydrea. 112 was hydrea versus interferon. What we saw was that interferon definitely is active. It definitely improved symptoms in patients in the second line. We're able to show that interferon's a good drug, but it still can have some additional side effects, including sometimes some flu-like symptoms or fever, some inactivity that can sometimes occur with hydrea. Now, we asked a question: if you come in without symptoms and start on a medicine, is it going to make you feel better, worse, or the same? And not too surprisingly, if you come in feeling reasonably well, if you start on a medicine, the side effects of the medicine, you'll notice them. Not overwhelming, but you'll notice them. And were not a major factor for people stopping the therapy. On the flip side, on the bottom side of this graph, if you started with a lot of symptoms, being on the medicine definitely helped you improve the symptoms significantly. And this is important as doctors think about therapies. You're always thinking about the trade-offs. You know, why would we start therapy for someone if they were feeling okay? The reason for it is that in these diseases, we're trying to do more than one thing. We're trying to protect against the risk of blood clots and bleeding and try to reverse symptoms if present. But if somebody feels well but is at high risk of blood clots, it sometimes is an adequate trade-off to have mild symptoms from medicines to protect them from potentially life-threatening blood clots. On the flip side, if you have lots of symptoms, starting therapy may be justified even if the risk of blood clots is not high. Now, interferon alpha, recombinant interferon alpha 2b is of great interest. This is in the US Pegasus. This is ropegylated interferon that is approved in Europe that may become approved in the United States later this year. And this showing evidence suggesting both improvement in myelofibrosis, free survival, and overall survival with therapy with interferon versus hydrea in these long-term studies. There have also been some efforts looking at, do we need to continue interferon indefinitely? There's some data suggesting that it is possibly something that can be stopped. I think at this moment, it's still probably premature to do so. Now let's pivot toward myelofibrosis. In myelofibrosis, we diagnose the disease, we assess survival, and develop our treatment plan. It is myelofibrosis that has the greatest likelihood of becoming life-threatening. It is really myelofibrosis where I call up a colleague like Joachim Dieg or like Gene Palmer when I was in Mayo, Arizona, or like Paul Shaughnessy when I'm in San Antonio, or Uday Popat, who's at MD Anderson, or Sergio Giralt at Memorial Sloan Kettering. And we discuss the case and see, is this someone who we should be proceeding with medicines or a stem cell transplant? Stem cell transplant can cure myelofibrosis. The decision on whom should be transplanted and when is a complex decision. And anyone who says that it's a simple decision is not an individual facing that decision. I myself, my career has focused on the medical part of this equation, but in partnership with folks like Dr. D, who in parallel are not only doing stem cell transplant, but they're doing everything they can to learn about it, to make it safer, so that individuals that go down that path have a greater likelihood of success, and it can be life-saving for more individuals. And they clearly have made advances along those lines. Now, we start with frontline medical therapy. There's 2 approved at the moment, ruxolitinib or fedratinib. A second line, we can proceed with transplant if that was not chosen initially, or move on to another medication, or progress to medicines we use for accelerated or blast phase. In 2021, there are really 4 JAK inhibitors to know, the 2 that are approved, ruxolitinib and fedratinib, and 2 that are on the cusp of approval, both pacritinib, completing current phase 3 clinical trials, being helpful for individuals with a low platelet count, and momelotinib, a medication, JAK inhibitor that can also help to improve anemia, spleen, and symptoms, and may prolong survival. Now, there are many therapies that are currently in development. You'll see on here a couple dozen different agents that are being tested in myelofibrosis. There probably are over 10 phase 3 clinical trials currently going on in myelofibrosis, which is really an extraordinary number, many of which either alone, but many in combination with a JAK inhibitor. Now, we are finding that medicines are having an impact on helping people live longer. Is this true across all JAK inhibitors? Why is this occurring? All of this is under study. I do think that medicines for myelofibrosis that clearly are benefiting patients in terms of spleen, symptoms, potentially anemia, may be helping to prolong life. Now, likely the degree that they're prolonging life is not of the same magnitude that we might expect with a successful bone marrow transplant or stem cell transplant. So in some diseases, we have evolved where our medicines became so effective that we do many fewer transplants than we used to before, like chronic myeloid leukemia. In myelofibrosis, this is not the case, but perhaps that will evolve over time. Now, there are many things evolving. Historically, people received ruxolitinib alone. Some now also receive Inrebec or fedratinib alone. We think that over time, there likely will be further combinations. There is a current phase 3 trial that has just opened at my center, but also many others, called the Manifest study. That is a combination of a second drug, the BET inhibitor CPI-0610, with ruxolitinib compared to ruxolitinib alone. And data from an earlier study does suggest that it might be better than using one drug by itself. But it's crucial that that be proven and see if that is appropriate. Now, there are questions that continue to evolve. If we find that two drugs are helpful, would that be in everyone? Would that be a subset? Or would people be okay if they just started on ruxolitinib and then we add the second drug for those that have a suboptimal response? Questions we don't yet have an answer to. Now, the second question is, I showed you that there's over 20 drugs being looked at. Should we be adding other drugs to JAK inhibitors? Should we be using second drugs alone? There's a variety of them. This is just showing some of the data as it relates to improvement in spleen, the SVR, spleen volume, or in symptoms. As you see, none of them help 100% of individuals. So it's good that there's multiple options because everyone is different. We are expanding how we are thinking about how these drugs act in terms of improving fibrosis, genetic abnormalities, or survival. Now, finally, I say that there are many efforts that have been ongoing to try to better understand how else we could treat the disease. You'll be hearing from my friend and colleague, Christina Gowan, later in the meeting, who has been deeply interested in complementary approaches, as well as my colleagues, Jen Huberty and others, as we have worked together as the MPN Quality of Life Study Group. And there are many things that we're looking at: yoga, activity, nutrition, even cognitive interventions. We have done trials and show that yoga can be helpful. It has shown to be safe. It might help to improve mood. It might help to improve sleep. It can have an impact on symptoms. We know that sometimes just there are aspects that both meditation has been helpful, and my colleague Jen Huberty has been leading efforts developing modules within the commercially based app Calm to try to help to overcome anxiety, depression, and other issues in both MPNs and other chronic illnesses. We have a grant from the National Cancer Institute regarding this. Additionally, my colleague Leslie Padronos from Mayo Clinic has been working with psychologists regarding interventional modules to really help people overcome some of the stress and anxiety with the disease. There's been great interest regarding nutrition, both the keto diet amongst others, and Dr. Angela Fleischman at University of California, Irvine has been doing a variety of laboratory-based studies, even with animal models of different diets. People ask me, well, Dr. Mesa, is there one diet that is best? I can't say that we can answer that yet at this point. What I can say is that any structured diet probably is helpful, because it means you are paying attention to what you're eating, both in terms of composition and volume, and that probably benefits you. There are many planned studies, including multiple ongoing efforts for calm improving sleep, as well as other developments. So I'll leave you with these conclusions. It is important across MPNs that we really be mindful of how the disease is affecting you in working with you to determine a treatment plan that makes sense, to try to protect you against blood clots, to try to help how you're feeling, to be monitoring for any side effects of therapy, and to be looking for any evidence of progression. If therapy is not beneficial, it's important to change. None of these things are set in stone. Any of the therapies that I've shown you have had both people who really feel well on them or do not. It is a dynamic process. The JAK inhibitors and interferons have really made very important additions to the treatments that we have. There are many new therapies in development. They're exciting, and look forward to these being further developed. And finally, I do think that non-pharmacologic therapies may augment the treatment options for MPNs. I don't think they replace them. People say, well, can I do meditation instead of hydroxyurea? Unfortunately, I don't think that that would be wise. You know, these other therapies are complementary.